Now let's look more closely at the volume and pressure curves from the Wiggers diagram. First, we'll look at the volume of blood in the ventricle throughout each step of the cardiac cycle. In ventricular systole, or ventricular contraction, where blood is ejected from the ventricle, and in ventricular diastole, or relaxation, when the ventricle is filled with blood. We'll plot the ventricular volume on the y-axis versus time on the x-axis. And our arbitrary starting point will be during ventricular diastole here at the end of ventricular filling, where the mitral valve is open and blood is passively flowing from the atrium into the ventricle, slightly increasing that ventricular volume. At the onset of atrial systole, the volume in the ventricle increases slightly as the atrium contracts and pushes a small volume of blood into the ventricle. During isovolumetric contraction, both the mitral valve and the aortic valve are closed, so although the ventricle has begun contracting, there's no change in volume. However, when the pressure inside the ventricle exceeds the pressure inside the aortic valve opens and ejection can occur. When blood's ejected from the ventricle into the aorta, there's a rapid decline in ventricular volume, and this decrease in volume is most rapid during the first part of ejection. In the later part, less blood is being ejected into the aorta and the curve flattens out. Following contraction, the ventricle relaxes, and when the pressure in the ventricle drops below the pressure in the aortic valve shuts. During this phase of isovolumetric relaxation, both the mitral and aortic valves are closed, so there's no change in volume. Note that not all the blood has been ejected. There's still some volume, around 60 milliliters in this example, that remains in the left ventricle. As the ventricle continues to relax, the pressure inside the ventricle drops even more, and when it drops below the pressure in the atrium, the mitral valve opens. This allows blood to flow down its pressure gradient from the atrium into the ventricle, filling the ventricle. Initially, filling happens very quickly. That's because when the mitral valve first opens, the pressure gradient is the greatest. The curve then begins to flatten out as time goes on, showing that less blood is flowing into the ventricle. There are a couple of important volumes that we refer to often when we talk about the cardiac cycle. The first one is the left ventricular end diastolic volume, or LVEDV. This is the volume inside the left ventricle at the end of atrial systole, just after the mitral valve has shut, and it's the maximum amount of blood that's contained in the ventricle before it begins to contract. The next important volume is the left ventricular end systolic volume, or the LVESV. This is the volume of blood in the left ventricle after it has finished contracting, or at the end of systole, and it's the minimum amount of blood in the ventricle before the mitral valve opens and it begins to fill. We can use the left ventricular end diastolic volume and left ventricular end systolic volume to calculate a couple of important volumes that tell us about heart function. The first is the stroke volume, which is the total volume of blood that's ejected by the left ventricle with each beat of the heart. So that's just the difference between the maximum ventricular volume, or the left ventricular end diastolic volume, and the minimum ventricular volume, or the left ventricular end systolic volume after ejection. We'll calculate the stroke volume by taking the left ventricular end diastolic volume and subtracting the left ventricular end systolic volume. In this example, about 140 milliliters of blood was in the left ventricle at the end of diastole, and about 60 milliliters of blood remained in the left ventricle after systole. So that means that about 80 milliliters of blood was ejected by the left ventricle during this beat of the heart. We can also calculate the ejection fraction using these values. And the ejection fraction is the percentage of total blood volume that's ejected by the left ventricle with each beat of the heart. So remember that not all the blood is pumped out of the left ventricle during ejection. In this example, there's still about 60 milliliters of blood remaining in the left ventricle even after systole. So to find the fraction or percentage of blood that was ejected, we'll divide the stroke volume that we just calculated by the total amount of blood in the left ventricle before contraction, or the left ventricular end diastolic volume. So 80 milliliters divided by 140 milliliters, or about 0.57 or 57%. So in this example, about 57% of the total blood volume was ejected from the left ventricle with this beat of the heart. Now we'll look at pressure changes in the left heart during each phase of the cardiac cycle. Left ventricular pressure, here in red, has the widest dynamic range. Its lowest values are around the low values for the very low pressure left atrium, and its highest values are around the high values of the high pressure aorta. Left atrial pressure, here in green, is relatively low, and this is in part because there are no valves that separate the pulmonary veins from the left atrium. This means that the pulmonary venous pressure and the left atrial pressure are about the same throughout the cardiac cycle, and so the left atrial pressure usually stays between about 5 and 8 millimeters of mercury. Aortic pressure, here in blue, is similar to arterial pressure, and it can be measured with an arm cuff. The aortic pressure peaks during ventricular systole at around 120 millimeters of mercury and has a minimum value during ventricular diastole at around 80 millimeters of mercury. These values, 120 systolic and 80 diastolic, are considered normal pressures. So now we can look in more detail at changes in pressure that occur during each subdivision of the cardiac cycle, and we'll pay particular attention to the valves opening and closing. So let's start with atrial systole. Here, a wave of spontaneous depolarization generated by the SA node spreads through the atrium and causes a contraction. This contraction results in an increase in atrial pressure, causing blood to be actively pumped through the open mitral valve from the left atrium into the left ventricle. Because the mitral valve is open and resistance of the valve is low, the ventricular pressure here parallels the atrial pressure. During atrial systole, the aortic pressure, here in blue, is slightly decreasing as blood flows out of the aorta and out into the systemic circulation. The wave of depolarization then spreads through the AV node and eventually into the ventricle, causing the ventricle to begin contraction. As the ventricle starts to contract, the ventricular pressure begins to rise. And when the pressure in the ventricle exceeds the pressure in the atrium, the mitral valve closes. This leads to the period of isovolumetric contraction, where the ventricle is contracting against closed mitral and aortic valves. So since no blood is flowing in or out of the ventricle, the volume of blood in the ventricle remains constant. And since there's no change in volume, there's a significant rise in pressure as the ventricular contraction continues. As the ventricle contracts, the ventricular pressure eventually rises above the aortic pressure, causing the aortic valve to open and allowing a pathway for blood to be ejected from the ventricle into the aorta. As the ventricles continue to contract, the pressure in the left ventricle continues to rise and blood is ejected into the aorta, causing a rise in aortic pressure. When ventricular contraction is complete and the ventricles begin to repolarize, the pressure in the ventricle begins to decrease, and as the rate of ejection of blood into the aorta decreases, the aortic pressure also drops. At this point, the pressure in the ventricle, here in red, falls slightly below the pressure in the aorta, but the aortic valve remains open. This is because of the momentum of blood flow. The blood's flowing so fast that it does not allow the aortic valve to shut back. This bump in pressure here in the left atrium is actually due to the large increase in ventricular pressure. That increase in ventricular pressure causes the mitral valve to bulge back into the atrium. And this decrease in volume of the atrium leads to a slight increase in atrial pressure. Then throughout ventricular systole, the pressures in the left atrium are increasing as blood's continuously flowing back into the atrium from the pulmonary veins. As the ventricle relaxes, eventually the ventricular pressure falls below the aortic pressure, causing the aortic valve to close and flow to stop. Now the aortic valve and the mitral valve are closed and the ventricle's relaxing. So there's a steep decline in ventricular pressure, but no change in ventricular volume. This is isovolumetric relaxation. During the later part of ejection and isovolumetric relaxation, there's a slow increase in pressure of the left atrium as a result of that venous return. Blood flows back into the left atrium from the pulmonary arteries. Eventually, the pressure in the relaxing left ventricle drops below the pressure in the left atrium, causing the mitral valve to open. Opening the mitral valve allows blood to flow down its pressure gradient from the left atrium into the slightly lower pressure left ventricle. As blood passively flows from the atrium into the ventricle, the pressure in the ventricle slightly increases throughout the filling process. At the same time, blood's continuously flowing back into the left atrium from the pulmonary veins. The pressures in the left atrium and left ventricle are both slightly increasing and they're close to each other. That's because under normal circumstances, this open mitral valve doesn't provide any resistance to blood flow, so the pressure of the atrium and the ventricle mirror each other. During this time, there's a decline in aortic pressure, and that's because blood's flowing out of the aorta into the systemic circulation with this closed aortic valve. And then we're back again to our initial starting point at atrial systole. The pressure changes in the right heart throughout the cardiac cycle look very similar to those that occur in the left heart, but the pressures are much lower, with a maximum pressure of around 30 millimeters of mercury in the right heart, as opposed to the 120 millimeters of mercury that we saw in the left heart. Just as is true for the left heart, the pressures determine what's measured as systolic and diastolic arterial pressure. Except in this case, it's the pulmonary artery that's being measured. If the pulmonary arterial pressure is 25/10, this means that the highest pressure in the pulmonary artery is 25 millimeters of mercury during systole, and the lowest the pressure gets is 10 millimeters of mercury during diastole or ventricular relaxation. The pressures in the right atrium are approximately equal to the central venous pressures, or the pressure in the large veins like the inferior and superior vena cava. And that's because there's no valve separating these large veins from the right atrium.